Welcome to this Pearl of Laboratory Medicine brought to you by AACC and the Clinical Chemistry Trainee Council. View this and many more pearls as well as other free educational material at traineecouncil.org.
Hello, my name is Dr. Kamran Mirza, and together with my resident, Dr. Adil Ahmed, we would like to welcome you to this Pearl of Laboratory Medicine on acute myeloid leukemia. The accepted paradigm for hematopoiesis begins with a multipotent progenitor cell. This cell has the ability to differentiate into any hematopoietic cell. It also has the ability for self-renewal. In general, it is thought that this cell leads to the common lymphoid and myeloid precursors, which can then differentiate down paths to make all the cells of the hematopoietic system. Any cell in this system can undergo malignant transformation that leads to uncontrolled growth. An acute leukemia is defined as the uncontrolled clonal expansion of hematopoietic progenitors or blasts. Acute leukemias typically present with symptoms of impaired hematopoiesis and bone marrow failure due to the crowding out of normal marrow by malignant cells. Patients may present with recurrent infections due to neutropenia, bleeding or bruising due to thrombocytopenia, and weakness or lethargy due to anemia. Since these progenitor cells can become either lymphoid or myeloid cells, two main types of leukemia exist. Expansion of blasts in the myeloid lineage leads to acute myeloid leukemia, and acute lymphoblastic leukemia, which is the lymphoid counterpart of AML, is discussed separately. Acute myeloid leukemia is the most common type of acute leukemia in adults, accounting for between 3 and 5 cases per 100,000 people in the United States. Acute myeloid leukemia can arise de novo from blast cells, be associated with an underlying hematological disorder, be a result of prior chemotherapy, or be associated with congenital disorders such as Down syndrome. It is thought that continued accumulation of chromosomal abnormalities or genetic mutations leads to the formation of chimeric proteins that alter the maturation process of myeloid blasts, leading to uncontrolled or unchecked growth of these cells without any maturation. The World Health Organization classification of tumors of hematopoietic and lymphoid tissues requires 20% blasts either in the blood or the bone marrow to make a diagnosis of acute myeloid leukemia. Some considerations or exceptions to this rule include, first, certain cytogenetic abnormalities such as translocation 821 and inversion 16 do not require a count of 20%, since just the presence of these abnormalities is diagnostic of acute myeloid leukemia. Second, pure erythroid leukemia requires over 80% of the bone marrow cells to be erythroid progenitors, with more than 30 of those being pro-erythroblasts. Third, in the case of acute promyelocytic leukemia, or APL, abnormal promyelocytes are also counted blasts equivalent. Lastly, in extramedullary presentations of acute myeloid leukemia, which are known as myeloid sarcoma, these may not have 20% blasts in the blood or bone marrow. To establish a diagnosis of AML, we need to confirm that the cells being counted are truly myeloblasts, since morphologically, myeloid and lymphoid blasts could have similar features. For this, ancillary tests such as immunophenotyping by flow cytometry and/or immunohistochemistry and cytochemical stains can be performed. The second question is of enumerating the blasts. This can be done by differential counts of the blood or bone marrow. Sometimes CD34 immunostaining or assessment of cellular events in the blast gate or flow plots are thought to help in this enumeration. However, not all blasts are CD34 positive, and the flow specimen may not be representative of the marrow. Therefore, flow and IHC should not be used to establish the 20% cutoff. Morphologically, myeloid blasts are large cells with a high nucleus to cytoplasmic ratio. Typically, there is a fine chromatin pattern with one or more nucleoli within the nucleus. The cytoplasm can be variably granular. The presence of our rods, as indicated by the arrow, is a defining feature of the myeloid lineage. The presence of myeloperoxidase can be confirmed by a cytochemical reaction. In this blast, the myeloperoxidase is present in blue. Immunohistochemistry for stains such as CD34 helps estimate the overall numbers of blast cells in core biopsy or clot specimens. expression of myeloperoxidase by either cytochemical reaction, immunohistochemistry, or flow cytometry is considered evidence of myeloid differentiation. Monocytic differentiation demonstrated by nonspecific esterase cytochemistry, lysozyme immunohistochemistry, CD14, CD64, or CD11C is also used to help define myeloid origin. While CD117, CD13, CD33, CD65, CD14, CD15, and CD65 are commonly expressed by myeloid cells, they are not definitive markers of myeloid origin. Once the diagnosis of acute myeloid leukemia is established, the next step is subclassification. Over the past few decades, numerous classification schemes address the various types of acute leukemias. The French, American, British, or FAB classification from 1976, subtyping AML M0 through M7, was based on morphology and cytochemistry. The more recent WHO classification continues to include the scheme under acute myeloid leukemia, not otherwise specified. From 1976 to 2001, the FAB was used. In 2001, the WHO brought forward its classification of tumors of hematopoietic and lymphoid tissues. This scheme has subsequently been revised in 2008 and 2016. The WHO classification takes into account morphology, cytochemistry, immunophenotype, cytogenetics, molecular genetics, and clinical outcomes, making it a very robust system. The 2016 WHO classification includes the following main subtypes of acute myeloid leukemia and related precursor neoplasms: acute myeloid leukemia with recurrent genetic abnormalities, acute myeloid leukemia with myelodysplasia-related changes, therapy-related myeloid neoplasms, acute myeloid leukemia not otherwise specified or NOS, myeloid sarcoma, and lastly, myeloid proliferations associated with Down syndrome. In the recurrent genetic abnormality subgroup, the following abnormalities are recognized: acute myeloid leukemia with translocation 821, acute myeloid leukemia with inversion 16 or translocation 1616, acute promyelocytic leukemia APL with PML RAR fusion, acute myeloid leukemia with translocation 911, acute myeloid leukemia with translocation 69, acute myeloid leukemia with inversion 3 or translocation 33, acute myeloid leukemia megakaryoblast with translocation 122, and acute myeloid leukemia with BCR-ABL1 fusion. The acute myeloid leukemias with recurrent gene mutations are also contained within this group and include AML with mutated NPM1, AML with biallelic mutation of CEBP alpha, and AML with mutated RUNX1. Within this subgroup, acute myeloid leukemia with A21, inversion 16, and acute promyelocytic leukemia are regarded AML irrespective of blast count. This means that the finding of one of these three abnormalities on cytogenetics or molecular studies immediately imparts a diagnosis of acute myeloid leukemia even when the blast count has not reached 20%. AML with translocation 821 typically presents with needle-shaped hour rods. Salmon-colored granules that typically cloak part of the nucleus, and some blasts show large pseudo-Shediac-Higashi-type granules. These cases usually show expression of CD34 with dim CD33 staining, frequent expression of CD19, and a variable expression of CD56. AML with translocation 821 is associated with a high rate of complete remission and disease-free survival when treated with intensive consolidation therapy. Acute promyelocytic leukemia demonstrates two morphologic subtypes. The hypergranular variant, shown here, demonstrates abnormal promyelocytes and cells with numerous hour rods, as shown here. In contrast, the microgranular variant demonstrates bilobe nuclei, often with a coin-on-coin appearance, and these cells are devoid of obvious granules. Both variants demonstrate intense positivity for myeloperoxidase on cytochemical staining. This is one acute leukemia which is a true emergency, as many patients present in disseminated intravascular coagulation, and an early morphologic diagnosis can help start ATRA therapy. Typically presenting as an acute myelomonocytic leukemia, AML with inversion 16 may also present as isolated myeloid sarcoma at initial diagnosis or at relapse. Acute myeloid leukemia with inversion 16 or translocation 1616 is best known for its association with eosinophils at all stages of maturation, with abnormalities in immature eosinophilic granules. As shown here, these abnormal eosinophils demonstrate purple-violet granules, which sometimes are so dense that they obscure the nucleus entirely. Acute myeloid leukemia with inversion 16 is associated with a high rate of complete remission when treated with intensive consolidation therapy. With regard to other acute myeloid leukemias in the recurrent genetic subcategory, some salient morphologic features include AML with translocation 911 resulting in KMT2A MLL-T3A fusion demonstrates monocytic features and is associated with intermediate survival. AML with translocation 6-9 may demonstrate monocytic features and is usually associated with basophilia and multilineage dysplasia. In both children and adults, acute myeloid leukemia with translocation 6-9 generally carries a poor prognosis. Acute myeloid leukemia with inversion 3 or translocation 3-3 frequently presents with increased platelet counts and demonstrates unilobed or bilobed dysplastic megakaryocytes. This acute myeloid leukemia usually has an aggressive course with short survival. Acute megakaryocytic leukemia with translocation 122 is very rare and commonly occurs in females with Down syndrome. AML with 122 responds well to AML chemotherapy with long disease-free survival. Acute myeloid leukemia with BCR-ABL1 fusion is a provisional entity in the WHO classification of 2016. These cases should represent a de novo AML with no evidence, with or without therapy, of previously diagnosed chronic myeloid leukemia. The morphologic features are nonspecific, but patients generally present with leukocytosis. It appears to be an aggressive disease with poor response to traditional chemotherapy. The diagnosis of acute myeloid leukemia with myelodysplasia-related changes requires the presence of several criteria. The cases should demonstrate more than or equal to 20% blasts. The second criteria requires either a family history of myelodysplastic syndrome or an overlap myelodysplastic myeloproliferative neoplasm, an MDS-related cytogenetic abnormality, or multilineage dysplasia. Of note, multilineage dysplasia itself is not sufficient to diagnose AML with myelodysplasia-related changes in a de novo case of AML with mutated NPM1 or biallelic mutation of CEBP alpha. This diagnosis requires the absence of prior cytotoxic or radiation therapy for an unrelated disease. And lastly, for this diagnosis, cases cannot harbor any of the abnormalities described in the AML with recurrent genetic abnormalities section. For an acute myeloid leukemia to be placed in this category based on morphology alone, greater than 50% of cells in at least 2 hematopoietic cell lines need to demonstrate dysplasia. This megakaryopoiesis is characterized by micromegakaryocytes, non-lobated nuclei, or nuclei with widely separated nuclear lobes. This erythropoiesis is characterized by megaloblastoid changes, nuclear irregularity, nuclear budding, and ring sideroblasts. Dysgranulopoiesis is characterized by hypogranular neutrophils, hyposegmented nuclei, Suter-Pelger-Huey anomaly, or bizarrely segmented nuclei. Acute myeloid leukemia with myelodysplasia-related changes generally carries a poor prognosis with a lower rate of complete remission than in any other AML subtype. Myeloid malignancies occurring as a late complication of cytotoxic chemotherapy and or radiation therapy from a prior neoplastic or non-neoplastic process qualify as therapy-related myeloid neoplasms. Cytotoxic agents implicated in therapy-related myeloid neoplasms include alkylating agents, ionizing radiation to large fields of marrow, topoisomerase II inhibitors, certain antimetabolites, and antitubulin agents. The presentation of these cases could be 20% or more blasts, which would be therapy-related acute myeloid leukemia or TAML, less than 20% blasts and dysplasia which would qualify as a therapy-related myelodysplastic syndrome or TMDS, or lastly, a therapy-related overlap myelodysplastic syndrome and myeloproliferative neoplasm. Irrespective of which entity a case may fall in based on the blast count in the blood or marrow, these cases are best regarded therapy-related myeloid neoplasms together, a unique category distinguished by prior iatrogenic exposure to the therapies listed above. Two main subsets of therapy-related myeloid neoplasms are seen with increased frequency. The more common are therapy-related myeloid neoplasms arising after alkylating agents and/or ionizing radiation. These tend to present 5 to 10 years after exposure and typically have a therapy-related myelodysplastic syndrome phase before therapy-related acute myeloid leukemia occurs. This subset is commonly associated with an unbalanced loss of genetic material, often chromosome 5 and/or chromosome 7. The second group has a shorter latency of between 1 and 5 years and occurs after exposure to topoisomerase II inhibitors. These cases typically present with over 20% blasts and often have balanced chromosomal translocations. Although strongly influenced by associated chromosomal abnormality, the prognosis is generally poor with overall 5-year survival rates of less than 10%. Cases of acute myeloid leukemia that do not fit any category within AML with recurrent genetic abnormalities or therapy-related disease are lumped together in the category of acute myeloid leukemia not otherwise specified. The subclassification within AML-NOS is based on morphologic, cytochemical, and immunophenotypic characteristics and extent of maturation in the blasts, often still referred to as the M types of the FAB classification. Excluding AML with NPM1 and CEBP alpha mutations, all subgroups of AML-NOS are not prognostically different, except pure erythroid leukemia. AML with minimal differentiation demonstrates no morphologic or cytochemical evidence of myeloid differentiation. Myeloid nature of the blasts is confirmed by the immunohistochemistry and/or flow cytometry study for MPO. The myeloid nature of AML without maturation is demonstrated by MPO positivity. This acute leukemia has a high percentage of marrowblasts without significant evidence of maturation to neutrophils. Maturing cells account for less than 10% of all nucleated marrow cells. AML with maturation reveals MPO-positive blasts. In these cases, the marrow demonstrates greater than 10% maturing cells of the granulocytic lineage. Of note, to be classified as M2, cells of monocytic derivation should be less than 20% of marrow cells. M3 is not listed here since it is acute promyelocytic leukemia. Acute myelomonocytic leukemia is defined when blasts and promonocytes together account for greater than 20% of cells in the blood or bone marrow. Additionally, neutrophils and their precursors and monocytes and their precursors should each account for greater than 20% of marrow cells. Cases of leukemia where over 80% of leukemic cells have monocytic derivation, including monoblasts, promonocytes, and monocytes, are subclassified as acute monoblastic and monocytic leukemia. In these cases, the neutrophil component is less than 20% of marrow cells. Acute basophilic leukemia is very rare, and acute panmyelosis with myelofibrosis presents with an abrupt onset of fever and bone pain. Pure erythroid leukemia is a neoplastic proliferation of immature cells committed exclusively to the erythroid lineage. Diagnosing pure erythroid leukemia requires greater than 80% of bone marrow cells to be erythroid cells, and additionally, greater than or equal to 30% of cells should be pro-erythroblasts. There cannot be a significant myeloblastic component. This is a very rare entity that can occur at any age, including childhood. There are no unique clinical features. Pure erythroid leukemia has a very aggressive clinical course with a median survival of 3 months. In the previous edition of the WHO classification published in 2008, an erythroid/myeloid category of erythroleukemia existed. This diagnosis was made when erythroid precursors contributed greater than 50% of all marrow cells, and myeloblasts were counted as a percentage of the non-erythroid cells. In the 2017 revision, such cases are classified as myelodysplastic syndrome if there are less than 20% blasts, and acute myeloid leukemia if greater than 20% myeloblasts are seen in the marrow or blood. Myeloid sarcoma, also known as chloroma or granulocytic sarcoma, is an extramedullary presentation of acute myeloid leukemia as a tumor mass. Infiltration of any site of the body by blasts is not classified as myeloid sarcoma unless it presents with a tumor mass in which the tissue architecture is effaced. Most cases arise de novo and have similar etiologies as conventional AML. Any site can be involved, but the most common organ affected is skin. In 1/4 of cases, myeloid sarcoma occurs in the absence of an underlying conventional acute myeloid leukemia. Clinical behavior in response to therapy do not seem to be influenced by age, gender, or anatomic site. An allogeneic or autologous bone marrow transplantation leads to a higher probability of prolonged survival and cure. There is an increasing recognition that some individuals or families with a germline predisposition face increased risk for myeloid neoplasms. The 2017 WHO classification acknowledges that constitutional symptoms and signs and family history are important clues to alert the pathologist to this group of myeloid neoplasms, which can have far-reaching consequences for entire families. There are three main categories within this subgroup. First is myeloid neoplasms with germline predisposition without a pre-existing disorder or organ dysfunction. These include AML with germline CEBP alpha mutations or myeloid neoplasms with germline DDX41 mutations. Second is myeloid neoplasms with germline predisposition and pre-existing platelet disorders. These include myeloid neoplasms with germline RUNX1, ANKRD26, and ETV6 mutations. And third is myeloid neoplasms with germline predisposition and other organ dysfunction, which include a mix of marrow failure syndromes, mutations, and importantly, myeloid neoplasms associated with Down syndrome. This last entity will be discussed in a separate pearl. Thank you for joining me on this pearl of laboratory medicine on acute myeloid leukemia.
For more like this, as well as articles, podcasts, and more, please visit the Trainee Council at traineecouncil.org.